welcome back. All right, our next speaker this morning is Dr. Armaghani. I was never mentioned your first name right. Sheyan. I was incorrect to say his first name. Dr. Sheyan Armaghani is a board-certified orthopedic surgeon who specializes in spine surgery. He received his fellowship training in adult spinal surgery at Emory University School of Medicine, widely considered one of the top spine fellowships in the country. As a spine surgeon specializing in degenerative spine conditions, he has a particular interest in the causes and treatments of neck pain and back pain, although he treats all spinal disorders. And he's actually my doctor. I've already seen him. He's awesome. Sorry. Dr. Armaghani uses a non-surgical approach and minimally invasive techniques with the goal of returning his patients back to enjoying their activities they love in the safest way possible. Please help me introduce Dr. Armaghani.
Thank you all for coming. I just kind of wanted to talk a little bit about these. Does everyone able to hear me? Sounds okay? Okay, great. So our objectives here are just to kind of identify common spine conditions that probably everyone in this room has experienced at some point in their life, and kind of go over some of those conservative treatments and some possibly operative treatments for it if it ever gets to that point. So low back pain is considered one of the most widely experienced health problems in the world. Everyone, I'm sure, sitting here has experienced back pain for at least some duration of time at some point in their life. Even 8 out of 10 people experience this. But next to the common cold, this is one of the main reasons that people miss work and go to see physicians. So how do I think about pain as it relates to the low back? Well, you have patients who have only back pain. You can actually have patients who have a spine-related disorder and they actually just have pain shooting down into their legs or in their buttock area, and so we kind of call that sciatica. And then you have patients who have both back pain and leg pain together. So when you think about the causes and things that can cause both back pain and leg pain, or back pain or leg pain individually, it can be several different things. And there's many, many different diagnoses in here. So the most common ones that can cause both issues with your back and your legs are things like disc herniations, spinal stenosis, and something called a spondylolisthesis, which is abnormal movement of your vertebrae causing pain. We'll go in a little bit more depth into these, so we all can kind of learn a little bit more about it. But then you have things that can cause only back pain and rarely, if ever, cause pain going down into the leg. And these are things like that you've probably read, if you've ever gotten an MRI or had someone with a X-ray tell you, things like degenerative disc disease. You have things like different aspects of scoliosis and stuff. All these things can cause and contribute to back pain. But then we have the old black box, and there are many, many reasons why people can have low back pain, but in 2018, we just simply don't know why they have that type of pain. We normally attribute it to muscular imbalances or weakness that can contribute and cause back pain over time. So we'll talk about just low back pain for now. And low back pain, again, is one of the most frequently encountered conditions in clinical practice, but risk factors are things that you would imagine risk factors for any chronic condition, mainly obesity, smoking, gender, lifting. If you're a laborer and you operate a jackhammer all day, that can cause problems. And also prolonged sitting at jobs. We have people who work in work in cubicles and work on computers all day, every day, and they can develop back pain close to the end of the week. So up to 84% of adult patients will have low back pain at some point in their lives. And over 1/4 of all the in the U.S. do adults report low back pain. So over here on the right side, we just kind of have what it looks like in a normal spine. And so degenerative disc is just kind of what I like to call normal aging. People, you'll get your MRI and you may read your doctor sent you somewhere because you have a degenerative disc, or they say they have degenerative disc disease. But what's going on really is that your radiologist is comparing you to a normal 18-year-old person with a perfect spine. So, I'm sure, except for maybe some of our younger people in the crowd, does anyone in here look like they did when they were 18 years old? I wish, right? So But the issue is you can't expect your spine to also look the same. So a degenerative disc is just like getting your first gray hair or your first wrinkle. It's just kind of part of normal aging. A bulging disc is also similar. A herniated disc is something much different. This is a severe outpouching of disc material that can cause pressure on a nerve that can cause pain that shoots down the leg. Low back pain has a high direct and indirect cost and is a common reason for missed work. So over $100 billion a year is spent on treating back pain. So this is a major concern financially as well. But the natural history of low back pain has shown improvements in pain within 1 month. So at least 58% of your total pain decreases if you have short-term low back pain. So you just kind of strained your back for a period of time. If you were playing golf or playing tennis, all of that will get better with time. 90% of low back pain will resolve within a year. Now that doesn't mean that you're not going to have flare-ups. We all have flare-ups from time to time if we're increasing our activity, if we're golfing more or playing tennis more. All that can increase your back pain or cause flare-ups. But the prognosis for acute low back pain without any leg pain, that's what that word radicular means, is pain shooting down the leg, is going to be very favorable. So there are some patients who have persistent symptoms, and in those patients who have continued symptoms over a month, you will see continued improvement between 4 and 12 weeks. So even if it's not better by a month, studies still show that it will continue to get better the vast majority of the time by 3 months. But in a minority of patients, low back pain without any pain shooting down the leg that lasts longer than 12 weeks, at which point you consider it chronic. So patients who have chronic low back pain account for the bulk of the cost as well as the economic hurt, not being able to go to the job, losing time off work, not being able to do the things you like. This is the people that have the most issues, is people who have back pain that lasts for more than 3 months. So predictors of chronicity, or predictors of people who will have pain more than 3 months, have various factors. They have some patients who just aren't doing well at baseline. You're not a weekend warrior. You're already having trouble moving around a little bit. These patients are at much higher risk of having pain that persists for more than 3 months. So what's the treatment? For almost all patients with just low back pain, non-operative treatment is the recommended treatment that I would tell almost everyone in the room. There's probably only less than 5% of different causes of low back pain, of just low back pain, that ever respond well to a reliable degree to surgery. And with patients who have acute low back pain, tincture of time is going to be the thing that's going to get everyone better here. Time is going to be the best cure. And in the majority, greater than 75%, they return to their baseline function within 3 months. So what is the treatment here? Anti-inflammatories are going to be the workhorse for it. You do have a lot of inflammation around the back that can develop, and that's just your body trying to heal itself. Opiates and muscle relaxers used with anti-inflammatories are no different than just giving somebody a sugar pill. So with patients who have low back pain, we are in an opiate crisis, currently in this country and worldwide. And despite what you may be prescribed or what you may be told, opiates do not do any different than normal ibuprofen anti-inflammatories for low back pain. Steroids are also no different than just giving somebody a sugar pill in terms of getting them better as well. But sometimes you still have patients with greater than 3 months of low back pain. They should still avoid using opiates unless they are under the direction of a pain management doctor, and that's just for safety, for safety's sake. But physical therapy is going to be the key, and the key is remaining active through pain to prevent stiffness. The problem is that if you pull your back out if you've been playing golf, or even did something small, like tried to, a lot of my patients, they come in, they say they hurt their back because they were pulling, wet sheets out of the washer. Just something like that can trigger back pain. What your body's doing when you're trying to get a spasm and you feel that horrible sharp pain and you feel that you're stuck and you can't move, that's your body trying to protect you from itself. Spine surgeons have only been around for like 50 years, right? I mean, we weren't around curing things, 100, 200 years ago. Your body's been fixing things on its own for thousands of years, and that's what your body's doing. Your body knew that you did something to hurt your back, and it know what it did to do it was twisting motion or a bending motion. So your mind knows, hey, I got to protect you from yourself. So your body, when you try to twist or something, your body grabs you and it tells you not to move, and that's the spasm that you feel. The important thing to know is not to be scared of that. That's just your body trying to protect you from itself. That's where our physical therapists come in really good. And what they do is they try to break this vicious cycle that starts where you hurt, right? And then whenever you try to move, your body tells you not to do it, so you don't move more. So then you start getting stiff. And stiffness leads to pain, which leads to more stiffness, which leads to more pain. Next thing you know, 3, 4, 5 months go around, and you can barely roll out of bed. And that's what happens to a lot of people. But trying to stretch in the face of that is the best way in breaking that vicious cycle. And that's what our physical therapists do by teaching our patients stretches and different exercises to work on their core and the flexibility in their lower back. And that's also something that's going to be lacking in almost everybody once you kind of get over 30. So we try to start our patients on a home exercise program when it first started, and if symptoms persist over 4 to 6 weeks, then we may send them to a formal physical therapist. So the first thing that we'll always get is we're going to get an x-ray of you if you ever come in, just to make sure nothing crazy is going on, not something in that 2% that can cause low back pain that we don't want to miss. But we typically almost always avoid getting something like an MRI in the acute phase. That's in the first month, unless there are any red flag symptoms. And red flag symptoms to us are sciatica or pain shooting down the leg, or if you're having any problems using the bathroom. So we talked about things for low back pain, but let's try to focus in on some of these other things that can cause back pain and leg pain. So these are the things that this is about 90+% of what I do on a daily basis. And I try to make things simple for patients. What I do isn't that hard. I do 2 things all day. I take pressure off nerves, and I take bones that are moving weird, and I make them stop moving. That's all I do, all day, every day. And that's what these things, and that's what these 3 diagnoses pertain to. And these cover over 90% of operative spine conditions. So a disc herniation, this is something that perhaps some people have experienced or know somebody that has, and this is a very painful, thing that can occur, and that's when the disc, which is you have your vertebrae here, above and below, and in between you have a disc which acts as the cushion. The disc can sometimes, for whatever reason, spit back outwards, and it can cause pressure on a nerve. And what you experience then is that searing, horrible pain that goes all the way down the leg. You know exactly when it happened. It can be very, very painful. And the thing that you're experiencing there is inflammation again. It's your body trying to fix things. And so it fixes things by sending cells down into your spine, and it tries to eat away that disc. And about 85% of the time, it ends up doing it. 75 to 90% of disc herniations improve with conservative measures. If you get a disc herniation, it is awful. It is the worst thing that you've felt, trust me. But I have patients come in 2 days, 3 days after it happened. They're in wheelchairs, they feel horrible. They come in, they see me 4 weeks later to check up on them. Again, 75, 90% of them, they're like, doc, I feel pretty good now. Just gotta let time do the trick. Time has been the best treatment for these kind of disorders and have been around the longest. But sometimes other things are help as well as physical therapy, anti-inflammatory, steroid injections. But if you fail those things and you still have pain after 6 weeks, then that's when I come in and we're able to pop that disc out. And it literally feels like taking a rock out of your shoe. If you have a rock in your shoe, you know that there's a rock in your shoe. And you may try to walk differently and move around differently so you don't feel it as much, but in the end, you just gotta take your shoe off and get the darn rock out. And that's what surgery is. Spinal stenosis is something that happens more in my retiree age patients. This is a gradual narrowing of the spinal canal that causes gradual pressure on nerves. And so you have a normal spine here. This is looking in cross section, so it's looking as if we like cut you in half this way. So your vertebrae is here. This bone right here is the bone you can feel when you're touching your back. Your spine lives in the middle. Spinal stenosis is when you have some narrowing of that area, and that can cause pressure on nerves and can cause leg pain, particularly when you're standing and walking. That gets better when you sit down. The reason why that is because when you're standing up and you take a normal posture, that area for the spine gets even smaller. So if you don't have much space to begin with, and then you stand up and that area gets even smaller, people start getting pain down their legs. But then, when they sit down, if you're anything like me, you slouch a little bit, right? And so when you slouch, you open up that space and you feel much, much better. So the treatment for this, usually it doesn't get much better with conservative measures can help with pain. Physical therapy, again, anti-inflammatories, and sometimes epidural steroid injections. But we consider surgery if you fail these conservative measures for at least 3 months. This is a lot different than a disc herniation, because a disc herniation, your body knows there's a problem, it sends cells down in there and it tries to fix it. Spinal stenosis is It is, yeah. The question was, is ibuprofen an anti-inflammatory? Yes. There are a billion names for it. Ibuprofen, Motrin, Aleve, Bayer, like all that stuff is our anti-inflammatories. The difference between this and a disc herniation is, again, your body's able to get rid of those disc herniations with cells, just like it can get rid of an infection in your body if you have a pneumonia or something. But the problem with spinal stenosis, this is a gradual process. This is a space problem. You just don't have enough space in your spine for your spine anymore. So it's very difficult to have medicines and things that are going to get you better if you have a space problem. So that's why a lot more of these patients end up going to needing an operation if they fail those measures over the course of a few months. And this is the last thing that we'll talk about, spondylolisthesis. This is abnormal motion of bones. These are bones that are moving weird or a little too much. And what that ends up causing is spinal stenosis. So spinal stenosis can just be caused by normal aging, and that can just happen over time, but it can also be caused by bones that are moving inappropriately. Treatment for this, same thing as all the others. Physical therapy, anti-inflammatories, and sometimes epidural steroid injections. We consider surgery for those who fail conservative measures for 6 months, because the difference here is, and again, I'll go back to what I said before, what I do is I only do 2 things all day. I take pressure off nerves and I stop bones that are moving weird from moving weird. You have a lot of pressure in your spine from spinal stenosis, but the cause of the spinal stenosis was the bones moving weird. So when the bones move weird, that's when you hear the dreaded fusion, the rods and screws. That's what you have to do. And so when you do that, that's why you want to wait a little bit longer to see if patients can treat this non-operatively or perhaps get better on their own, because you don't want to go out and start just fusing everybody left and right, because that can cause their own problems. You want to fuse them if there is a reason to fuse them. So just kind of putting all this together, the first thing that we do in our clinics if a patient comes in without anything is we just get an x-ray of them when they're standing, and that rules out a lot of the major abnormalities and red flag signs, but it also shows us your bones. It shows us if your bones are moving weird, if your bones are moving in a way that can cause things like spinal stenosis or a disc herniation. We obtain an MRI of your lower back only if you fail conservative measures for greater than 6 weeks or if your symptoms are worsening. But there's no benefit for an MRI in patients who have just chronic low back pain. And again, MRIs, those things are expensive. You come in with a week of horrible disc herniation, you're in pain. We understand it, but you're going to get better from it. 75 to 90% of people do. So, we typically save getting the MRI until we've proven that you're maybe one of those unfortunate ones that can't get rid of the disc herniation on their own. So our conservative measures is number one is just reassurance. Of people that come into my clinic, I only operate on less than 5% of everybody that walks in. So, the answer of spine surgery being being the kind of the end all, that is not the case for the vast majority of things that are seen in the community and are reserved for these very specific situations. And the reason why is because this is major surgery, okay? Once you do surgery on somebody, you're never quite like God made you, you know what I mean? So you want to make sure that you're doing it in the right situation so that the patient can get the most maximal result. Home exercise program and physical therapy is going to be the workhorse, as well as anti-inflammatories, and then we usually see patients in 4 or 6 weeks to see how they do with that, and then we go from there. And I think that concludes my talk. I thank everyone for their time.
All right, so I've got a microphone here. I assume there might be a few questions. So anybody have a question they'd like to ask Dr. Armaghani? We've got a couple in the front. I'm right behind you with a mic.
What's your take on chiropractic adjustments?
I think chiropractor is a great, is a great adjunct to other things like physical therapy. When we talk about chiropractic care, we take conservative measures are looked at in 2 different ways. We look at them as active modalities or ways to get better, and then we look at passive things. When we study thousands and thousands and thousands of patients who have low back pain, we find that if a patient is doing exercises and stretches on their own for themselves, that tends to do better than things like passive stuff, like a chiropractor doing an adjustment to you, a massage therapist, acupuncture, all that stuff. Now, it doesn't mean that doesn't get people better. Okay, chiropractors do wonders for many patients. But when you look at many patients on the whole, if you're doing exercises and stretches on your own, having an adjunct like a chiropractor, massage therapist is never going to do anything bad to you.
How long should the stretching exercises take?
Take like when you're doing them, so generally those things only take about 10-15 minutes to do, and I have my patients do them in the morning. We have the physical therapist, and they generally show them those stretches. It only takes a visit or 2 to learn them, and then you do them on your own. The key though is I'm looking at the crowd here. Who has cholesterol problems, right? Everybody, right? You don't take your cholesterol every day to decide whether you're going to take your pill or not, right? No, you take your cholesterol pill every day because it's good for you. When you have chronic back pain, your pill every day are core strengthening and stretching exercises and lower back flexibility. That's your pill. That's what's going to get patients better over time, but it takes a really long time because once you have the low back pain, you got to build up the strength, and then you got to build up the reserve for when you have the flare up for when you do go play golf or tennis or something or other.
Right here.
You talked about low back pain and leg pain. How about low back pain and numbness in your toes and lower extremities?
Those can be. I talked about pain. What I should have said is discomfort, because patients can perceive compression of nerve as many different things. They talk about it as burning pain, sharp pain, stabbing pain. Someone's put an ice pick in my back, like numbness, tingling, any number of those things. Generally though, if it is an issue coming from a nerve in the spine, it generally follows down a certain path. So it rarely does just in the back and then just in the toes. There are other causes of numbness and tingling that can only happen in the feet and generally have to do with different types of neuropathy. But those are generally not improved upon reliably with things like operation.
I have an inversion table that I've used over the years that makes my back feel much better with my compressed lumbar, etc. So what are your thoughts on the inversion table? Is that...
Have at it. What I tell patients is, if it makes you feel good, keep doing it. If it makes fiscal sense, keep doing it. What you don't want to get into is, kind of be, honestly like fed snake oil and have someone tell you, hey, if you do this for few $1,000s every time, you'll feel better. No, you don't do that. But generally, these kind of stretches, strengthening things, inversion table, if you have access to one and you find that that works for you, keep doing it. People ask me all the time, what's better for my low back, heat or ice? Whatever makes you feel good. Those things, that's not going to hurt you. If they make you feel good, keep doing it.
The specific stretching and exercises you do they differ by the type of injury or where the pain is, or is there just...
Almost never. It's usually generally the same thing for any low back condition.
What are some of those?
And I come to you.
I'm guessing you get the same questions I do about stem cells every day. You want to have a comment on stem cells in the spine?
I do. So my comment on stem cells, may get a lot of attention, but that's just how I am. So I don't care. I am a conservative person. Okay. I do not like doing things unless it's been shown to have worked in very, very detailed trials that have done on thousands and thousands of patients. If it ends up showing that that stem cells work, that's obviously something that I would add to my practice. The problem is right now is that there has not been a single study in the spine to show that stem cells do anything to help patients' back pain or disc regeneration. In addition, it is not approved by any insurances, and you have to pay out of pocket for those things. What I would tell you is if insurance is saying that something is experimental, you should not do it, because they're only doing things that have been shown and proven to work. If it ends up showing up in the next 5 to 10 years that stem cells show a benefit, my gosh, every insurance company will do it in a heartbeat, because stem cell therapy would be much cheaper than getting an operation and having patients have chronic low back pain. As it stands, stem cells typically range anywhere from $3,500 to $5,000 a shot and have no guarantee at any improvement for you. So I would tell you, and I'm going to get a lot of heat for this, I'm sure, but I would tell you, buyer beware for things that are not covered by insurance.
What about CBD oil or medical marijuana for pain? What's your thoughts on that?
I'll probably get a lot of heat for this too. If it makes you feel good, do it. It's not gonna hurt your back. It's not gonna hurt your spine. And that's my job. My job is when someone comes to me, I evaluate them to see if I can help them. Unfortunately, again, I do two things all day. I take pressure off nerves and I stop bones that are moving weird from moving weird. If I can't do one of those things, you're still seeing me because you're hurting. You need help, right? My job is then to figure out, are the things that you're doing going to hurt your spine structurally? CBD is not going to hurt your spine structurally, and I'd much rather you be doing that than opiates.
Questions behind me? Anyone else? All right, please give a round. Wait, sorry, we have one.
I think he had one as well.
I'm sorry, I didn't see hands.
I was just asking about the type of exercise.
I don't have any offhand. Generally what we'll do is we send our patients to a physical therapist one time. They show them like the structured exercises to do, and they demonstrate those exercises in front of them. And then once we kind of get the idea that you're able to do them on your own, that's when we kind of say, hey, keep it up, keep doing it.
Yeah, if you think like blood thinning, how long you gotta wait till you have like surgery or something like that?
It depends. It depends mostly on the cardiologist. The question was about blood thinners and when you can get surgery. Having blood thinners is not a contraindication for surgery, meaning if you're on I operate on people on blood thinners all the time. You just have to be off of it for a certain amount of time, and we talk to people's cardiologists or whoever's giving them the blood thinner to see how long is a safe amount of time to be off of it and when to restart it if it gets to that point.
Sorry, 2 more questions is what we got time for.
If you have arthritis in your lower back and hips and compression and everything, and there's some pain, does physical therapy stretching really help? Is it demonstrated that over time stretched muscles helpful to alleviate that pain?
That's a very good question. The question was, if you have an arthritic back, is physical therapy, stretches going to help with that? The answer is yes. If you think about it, when you have an arthritic joint, like in your knee, it generally hurts people when they're trying to move that knee, right? So when you have an arthritic back, you have two joints at every single level in your entire spine. So you have dozens of joints in your lower back that can get arthritic. When you are able to work out your core and lower back, your core and your lower back muscle strength becomes your internal brace, right? You see people walking around with braces sometimes on their lower back. It's your internal brace. It holds things still while you're moving around. So if you're able to do things like get your core very strong, strengthen your lower back, it stops some of that weird abnormal motion that you may be experiencing and can decrease arthritic type back pain over time. But again, this is one of those things that is not a quick fix and it takes a very long time to get better.
All right, I think that's all we have. Again, Dr. Armaghani will be over here if you have any additional questions, but please give him a round of applause and thank you. All right, we're going to take another 5-minute break before we get to our last speaker, Dr. Baker. So please be back here at around 11:15.